International humanitarian law prohibits armed actors from directing attacks on hospitals, refugee camps, and other zones established to shelter wounded and sick civilians from the effects of conflict. Even so, attacks on hospitals have become a common occurrence in many wars, including the ongoing crisis in Yemen. Throughout 2015 and 2016, hospitals in the country were targeted, damaged, and destroyed by parties to the conflict. In spite of the danger, organizations like MSF often step in to fill gaps in local and national medical capacity to continue providing healthcare from targeted facilities. This was the state of affairs for many hospitals in Yemen up until August 2016, when MSF decided to pull staff from 6 hospitals in the northern regions of the country. The decision was made as a result of continued attacks on healthcare facilities where MSF staff worked, and the lack of a guarantee that such attacks would stop. After MSF's withdrawal, many communities lost access to healthcare. As the war continues, many more lost access to clean water and sufficient nutrition. Enter Shinjiro Murata, former head of MSF's mission in Yemen. When he entered the role in 2017, Shinjiro was tasked with resuming medical activities in northern Yemen hospitals that had been attacked. As a seasoned leader with prior experience in South Sudan and Syria, Shinjiro was equipped to deal with the challenges that would come his way, but he was not expecting what would come next. Towards the end of March 2017, a patient exhibiting severe abdominal pain, dehydration, diarrhea, and vomiting arrived at an MSF-run hospital in Abs. A project coordinator working in Abs hospital promptly called Shinjiro to deliver the news of what doctors suspected was afflicting the patient: cholera. Cholera, in low-resource settings, poses a massive challenge for humanitarian practitioners and affected communities. The disease most often spreads through consumption of water that is contaminated by the feces of a cholera victim. In communities that lack access to clean drinking water, the disease is highly contagious and can quickly overwhelm public health infrastructure. With proper treatment, individual cases have high survival rates. The challenge is in managing the volume of cases and spread of disease, quarantining effectively, and ensuring communities have access to clean water for hydration and sanitation.
When I got a phone call from my project coordinator in field in the end of March, first I didn't believe this information, because historically speaking, in Yemen, we didn't have the cholera outbreak. So we were not preparing ourselves completely for the big outbreak.
After confirming the patient's condition, Shinjiro and the MSF staff under his direction began the process of identifying the cause of the outbreak and managing its spread. Part of this process meant visiting the communities of infected individuals and assessing possible sources of cholera, such as interrupted access to clean drinking water or lack of waste management systems due to the ongoing conflict. Unfortunately, the conflict further complicated the effort to curtail the outbreak.
Our movement was restricted by the local official security authority because of the war, a lot of tensions were mounting, which we could understand. It took a time for us to get an authorization to move around. That was also a bit difficult challenge for us to react promptly for the outbreak. Then when we were still in the negotiation with the authority to gain access to communities, we started to receive patients not only from one village, but from plural different villages. Then it's not only in one hospital, but in different hospitals, in different governorates.
In Yemen, the war created a complex situation where access to affected populations was a consistent challenge. The travel restrictions imposed upon Shinjiro and his team were just one of many variables that were out of the control of any single person or institution. There was also the problem of community resources. Even after Shinjiro gained permission to travel, members of many communities didn't have the means to travel to treatment facilities without foregoing other necessities, such as food and education for their children. It's hard to pinpoint how much any one barrier to humanitarian access impaired the cholera response. But as the outbreak grew in scope and intensity, additional obstacles to access meant fewer people being treated, more contaminated water, more cases of infection, and more lives lost.
So because of these plural different challenges, it was not easy for anybody to scale up our capacities to respond to this world's worst cholera outbreak, which delayed the response, and also which led to probably the widely spread the outbreak in Yemen as a consequence. Finally, thanks to the effort by all international organizations, together with Ministry of Health, locally recruited staff, we managed to control the break, but still it's ongoing. It's still ongoing.